Hello, everyone, and a very good morning, afternoon, or evening to you, depending on what part of the world you're joining us from. My name is Abdul Bachani. I'm an associate professor in the Department of International Health and the Health Systems Program at the Johns Hopkins Bloomberg School of Public Health, where I also serve as director for the Johns Hopkins International Injury Research Unit and the program director for the Learning, Acting, and Building for Rehabilitation in Health Systems program. On behalf of the Johns Hopkins Bloomberg School of Public Health's International Injury Research Unit and the Relab Hs Consortium, I really would like to extend a very warm welcome to each and every one of you. And thank you for taking the time out of your schedules to join us for our global launch event for the Learning, Acting, and Building for Rehabilitation in Health Systems program. Today's event is not only an exciting milestone for the Relab Hs Consortium and our partners, but I feel it also marks a significant leap forward for the fields of health systems and rehabilitation. We all know and acknowledge that rehabilitation is integral to the overall health and well-being of individuals, and these services do help people lead full and independent lives. And recent estimates show that 1 in 3 people across the globe will require rehabilitation at some point in their lives. However, when it comes to health systems, rehabilitation has often been overlooked. Improvements in healthcare over the last decade have meant people are living longer. The proportion of the population over 60 years of age will double in the next 30 years, and they will live with the concurrent illnesses
What if she barks on this side?
And disability that are part of
like
the aging process. Approximately 150 million people,
out of the yard.
Approximately 150 million children and adolescents experience disabilities. We have rapid urbanization and concurrent increases in motorization that leave people vulnerable to injuries. And in addition to the influence of diseases and their consequences, we live in a world that faces political, economic, and environmental flux and shock. Conflict and wars beset many settings. And now with COVID-19, a disease that appears to manifest as long-term chronic ill health in many, has demonstrated that we live in a world where both communicable and non-communicable diseases must be tackled simultaneously. And we're finding that already stressed health systems in low and middle income countries face challenges, including poor infrastructure, few specialized care providers and trained professionals, and inadequate financial resources. With USAID's generous and timely support, the Relab Hs program hopes to directly address the critical need for access to appropriate and effective rehabilitation services and assistive technology through contextualized, efficient, and sustainable solutions with an emphasis on access at the local level. So we see today's event as just a beginning in a long series of conversations we all have together as we work to strengthen health systems and really make them more responsive to the needs of the populations they serve. And in the process, we hope to make sure that rehabilitation services are no longer overlooked and are integral part of the discussion when it comes to strengthening health systems. And so without further ado, I would like to welcome Dean Ellen McKenzie, the Dean of the Johns Hopkins Bloomberg School of Public Health, for a few opening remarks. Dean McKenzie is an expert in trauma care and health policy and management and an elected fellow of the National Academy of Medicine. And through her career, she has recognized the key role that rehabilitation services have in improving health outcomes for individuals and has really championed this cause. And therefore, it's doubly exciting to have her here to kick us off. Dean McKenzie, over to you.
Well, thanks so much, Abdul. And I'm just so delighted to be with you, albeit virtually, for the global launch of this incredible program. As you know, the work of the Bloomberg School saves and improves lives millions at a time around the globe by pioneering new research, deploying its knowledge and expertise in the field, and very importantly, training scientists and practitioners in the defense of human life. As the first independent degree granting institution for research in epidemiology and training in public health, the Bloomberg School remains steadfast in protecting health and preventing disease and disability in the US and around the world. We work at the global level as well as regionally to push the boundaries of science and translate the research and discoveries into effective interventions for improving the health and well-being of populations, with a particular emphasis on those who are historically underrepresented and underserved. The school has a long history of partnering with US government agencies and contributing to their commitments across many critical health issues. And we are thrilled that this partnering is now extending to the area of rehabilitation. I'm excited for the Bloomberg School to be part of this major investment of USAID. This groundbreaking effort will bring rehabilitation services to the forefront and find avenues for its integration in health systems in low and middle income countries. And as Abdul just said, and you all know only so well, rehabilitation is overlooked, often overlooked, despite its essential role in providing services that help individuals lead full and independent lives. And as Abdul mentioned, I know from my own work in trauma outcomes that access to rehabilitation is often the critical missing link in the overall systems approach to effective treatment of traumatic brain injury, spinal cord injury, musculoskeletal trauma, and overall in trauma outcomes. With USAID's generous support, this project will be equipped to directly address the critical need for more reliable data and customized rehabilitative care around the world, with an emphasis on access at the local level. I'm proud of the Bloomberg School's long-standing partnership with USAID, but also with our partnerships with the University of Melbourne, United Cerebral Palsy, Wheels for Humanity, Humanity and Inclusion, Physiopedia, and Miracle Feet. We recognize the remarkable work that all our partners are doing in the field, and I'm also confident in the staunch leadership of Abdul and the Johns Hopkins International Injury Research Unit that they bring to this project. Through this investment, I'm confident that we will not only develop and implement approaches to reach those most in need to improve their health and well-being, but also to strengthen health systems overall and lay the groundwork for sustainability and future investments. Again, thanks so much for joining us today for the launch of this incredibly important program that will bring rehabilitation closer to those affected individuals and where they live. Thank you.
Thank you, Dean McKenzie, for those remarks. And as Dean McKenzie mentioned, we really wouldn't be having this event if it weren't for USAID recognizing the urgent need for a more holistic, systems-based approach to improving access to appropriate and effective rehabilitation services. This approach, as many of you know, is a strategic change in direction from the traditional approaches of vertical rehabilitation programs. And such efforts usually require champions from within. One of those champions is Kirsten Lenz, Kiki, who's a senior rehabilitation advisor within the Inclusive Development Hub in the Bureau for Development, Democracy, and Innovation at USAID. And I'd like to now invite her to share some of her perspectives on behalf of USAID. Kiki is the activity manager for the Leahy War Victims Fund portfolio, through which the Relab Hs program is being funded. Kiki.
Thank you, Abdul. And thank you to everyone who's joined today, especially our keynote speakers, our panelists, and colleagues from around the world who have taken time to be here with us for the global launch of the Learning, Acting, and Building for Rehabilitation in Health Systems, otherwise known as Relab Hs. I'm only going to say a few words since the dynamic Relab Hs team, our speakers and panelists, will provide you with more information and discussion about physical rehabilitation that is inclusive of assistive technology in health systems and on the global health agenda, and of course, an introduction to the Relab Hs activity. It's inspiring to have so many people join the launch of Relab Hs from around the world. I think it's a real testament to the growing interest in physical rehabilitation, the integration of physical rehabilitation into health systems, and the acknowledgement of the important role that physical rehabilitation plays in comprehensive health services, as well as the positive impact on functioning for the estimated 2.4 billion people that would benefit from physical rehabilitation and assistive technology services. About 3 years ago, USAID took time to reflect on lessons learned, achievements from the investment in physical rehabilitation and assistive technology through the Leahy War Victims Fund and the Wheelchair Program Fund. In that pause, we identified several opportunities, challenges, and directions for future investment. It was clear that if we want to strengthen access to and availability of quality, sustainable physical rehabilitation and assistive technology services, we had to reframe rehabilitation services as an integral part of the health system to allow continuity of care. As we worked on this reframing, we started asking questions such as, are health systems able to recognize rehabilitation needs of the population, especially in low and middle income countries? How prepared are systems to provide rehabilitation services? Do populations understand their rehabilitation needs and know where to seek them and when? And how well is rehabilitation integrated as a core service within the health system? These broad questions, which call for solutions grounded in principles of systems and implementation science. Relab Hs's innovative learn, act, and build approach to integrate and strengthen rehabilitation into health systems provides an opportunity to develop, adapt, implement, and evaluate solutions to address physical rehabilitation and assistive technology needs in fragile and low and middle income settings. Relab's focus will strengthen capacity and develop tools to guide policy and prioritization, improve service delivery across all levels of care, and develop and test novel solutions that are demand-driven and contextually relevant. Relab Hs will begin its activities in diverse countries such as Pakistan, Uganda, and Ukraine, and this work will inform scale-up and sustainability of solutions for implementation in other settings. USAID, through the Leahy War Victims Fund, the Wheelchair Program, and the Disability Program, is planning to invest $39.5 million over a 5-year period in bringing about transformative change and systems thinking to address issues surrounding the integration of physical rehabilitation and assistive technology within health systems, particularly in conflict-affected countries. Again, I want to thank you all for joining today, and I really look forward to engaging with you in the future. Thank you, and back to you, Abdul.
Thank you, Kiki, for those remarks and for really being such a strong advocate for a systems approach to strengthening access to rehabilitation services and assistive technology. I would like to now invite Professor Barbara Mcpeak, the director for the Nozzle Institute for Global Health at the University of Melbourne and current chair for Health Systems Global. Barbara will also be serving as co-program director for the Relab Hs program. Barbara.
Thank you very much, Abdul, and it's a privilege to be working with you on this program. And I'd just like to say that I'm delighted that USAID has had the foresight to invest in this program, and I'd really like to take the opportunity to thank them as well for their leadership in this area. Now, obviously, rehabilitation assumes a particular importance in the context of epidemiological and demographic transitions, where we have more chronic illness and more older people, all of whom need to benefit from rehabilitation services. And it's also particularly important in settings recovering from conflict, where we have high levels of traumatic injury. And economic transition is also important. We're moving towards a middle income world in which there are new challenges and new opportunities. And these challenges and opportunities have health systems dimensions. For example, the challenges for health systems to pivot from a maternal and child health focus to addressing the full set of issues across the population pyramid, with implications for things like workforce, team working, and the demedicalization and the recognition of the many different professions that are needed in health systems. And there are also opportunities from technological transition that arise And here I think we are particularly pleased to be working with our colleagues from the non-governmental organization sector, Humanity International, Physiopedia and UCP Wheels, who've already been mentioned. Now, at the Nozzle Institute, I think we have a particular set of skills that align with what this program is trying to do. We're aiming to be systems thinkers, primary focus on health systems in the Institute, which we're defining increasingly broadly to recognize all the elements of the systems that shape health, including, for example, social determinants. And our disability unit, led by Alex Robinson, and with the membership of Wes Pryor, who's been very much the spark and the engine of this program from our side, has for a long time had a major focus on rehabilitation services. So for example, Wes has worked previously on contributing to the idea of an essential list of assistive devices to parallel the essential list of medicines that's been such a key tool for health systems for some time. And we're also really pleased about the opportunity to learn from and build on recent efforts to integrate rehabilitation in the South Pacific. So working on this with the Murdoch Children's Research Institute and their Fijian counterparts, who've been transforming how children access rehabilitation and how the health system responds to increased demands for identifying and supporting children and families who might benefit from rehabilitation, assistive technologies and other care. And lastly, I just want to say that we're also looking forward to understanding how innovative technologies are playing a role in integrating rehabilitation and other services in local communities in Laos, together with World Education Laos. So really delighted to be here tonight. Obviously this program, this moment comes at the end of a long process of establishing this program, and it's a great milestone to be here now and to see so many people interested in what we're planning to do. So thank you very much.
Thank you, Barbara. So, and as we prepare to look forward, it's really important for us to take a moment and understand what has led us to this point and what the current state of play is. And it's only when we stop for such reflections that we're able to identify opportunities and anticipate pitfalls that we should avoid going forward. Therefore, as we embark on this journey of integrating rehabilitation into health systems through the Relab Hs program, we'd like to take a moment to understand and reflect on where we are with respect to health systems and rehabilitation, which is going to be the focus of the next session in today's event. To chair this session, I'd like to invite Dr. David Peters. Dr. Peters is a professor for international health and chair for the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. David also serves as chair for the board of the Alliance for Health Policy and Systems Research, and he's an expert in health systems. He's worked as a researcher, policy advisor, educator, manager, and clinician in dozens of low and middle income countries. And his work really seeks to improve the performance of health systems in low and middle income countries through implementation science, building institutional capacity, and applying innovations in organization, technology, and financing with a focus on improving health equity. David, over to you.
Thanks, Abdul. And first of all, thank you for the opportunity to join this really exciting launch of the Relab Hs program. It's really a landmark program, both for disability and rehabilitation programs, but also to have more complete and equitable health systems. I particularly appreciate the approach that involves learning, capacity building, and collaboration. And in that, I would like to, again, congratulate USAID and the full range of partners, and also to you, Abdul, and the International Injury Research Unit that's pulling this together. It's really quite exciting. My main job is really to introduce some speakers we have today. It's gratifying to have two leaders from World Health Organization who are going to be talking to us today in this session. I would let people know at the end of their presentations, we're going to have an opportunity to have some discussion. So if you have questions, please put them in the Q&A section, which is at the bottom of your Zoom screen. If you put them in chat, we'll try and capture them there as well, but we'll give some opportunity for that, that as well. Let me then first introduce the first speaker. I'm delighted to introduce Dr. Larcos Sieza. She's the head of the World Health Organization's work on vision, hearing, disability, and rehabilitation in her position as the unit head of sensory functions, disability, and rehabilitation. Prior to joining WHO, she served as chair and professor of the medical psychology at the Faculty of Social and Human Sciences at University of Southampton. And prior to that, she had spent over 10 years leading a research unit in the Department of Physical Medicine and Rehabilitation at Ludwig Maximilians University in Germany. So with that, I'm delighted to turn over the mic to you, Dr. Sieza.
Thank you. Thank you so much for that introduction. And I'm also extremely pleased to be here today. So my objective today is to introduce to all of you Rehabilitation 2030. And I will do that based on 3 words that represent the core of Rehabilitation 2030. And these 3 words are equity, needs, and response. And I will go through each of these words with all of you in the next few minutes. Let's start with equity. And at the heart of Rehabilitation 2030 and its driving force is indeed equity. And it means that everyone who needs rehabilitation services receive quality rehabilitation to optimize and maintain their functioning in everyday life. And it is also a question of rights. Is the right to achieve the higher possible level of functioning when one has a health condition or several health conditions. And here I think often of my friend Kate Gafar, who you may know. She's someone who was diagnosed with dementia 13 years ago. And Kate always said very clearly, thanks to rehabilitation, she's able to continue working and she's able to be independent, and only because of rehabilitation. And we want that for everyone needing rehabilitation. It does independently of where they live. It can be Australia, it can be Armenia, or it can be Nicaragua. And that is the aim of 2030. And the core here is equity through equality of access. And that is important to emphasize, because the reason there is equality of access to rehabilitation is the reason why universal health coverage has been fundamental and foundational for Rehabilitation 2030. The good news has been always that WHO in its definition of universal health coverage has already included rehabilitation as the provision, and we define universal health coverage as the provision of quality health services for promotion, prevention, treatment, rehabilitation, and palliation according to the need and without financial hardship. So that is for equity. Let me now go into needs. And as it has been already mentioned today several times, Rehabilitation 2030 has been about uncovering the huge rehabilitation need around the world. And as we have heard, based on the recently estimates published by WHO and by the Institute of Health Metrics and Evaluation, 2.4 billion with B, and it is important to repeat, 2.4 billion people around the world today have limitations in functioning severe enough to benefit from rehabilitation. And this includes people with neurological conditions, with pulmonary conditions, with cardiovascular diseases, with, I don't know which one I repeated, but all of these conditions, but also some of them that we don't think often when we talk about rehabilitation. And this is mental health conditions and also vision and hearing impairment. And most importantly, as we are experiencing today with COVID-19, rehabilitation also relevant for infectious diseases. And also people from all ages. And putting out the huge need for rehabilitation is making possible also to put rehabilitation out of the cage in which we have been putting it for so many years. And that allows us to say that rehabilitation is not only a highly specialized services to be delivered at tertiary level. Actually, that rehabilitation needs to be completely integrated at secondary level and most importantly, at primary level, because there is where rehabilitation can benefit most people in need. Imagine, simply imagine, people where all people that after stroke live in the community, how much helplessness, how much dependency, and how much lost productivity could be reverted if they could have quality rehabilitation close where they live. And through that, through uncovering the need for rehabilitation, we have been able also to make the case that rehabilitation is not only a service for the few and those with long-term impairment, but health strategy that is important for public health and to meet the needs of 1/3 of the world population. And to end the work on needs, I would like also to point out to the real challenge, because the real challenge is the huge unmet needs across the world. We know that in many countries of the world, not more than 50% of those who need rehabilitation have access and receive that rehabilitation they need. So it was equity, it was needs. Let's go to response. Because what Rehabilitation 2030 is a call for action to respond to that huge need for rehabilitation around the world. And the call for action is about a strengthening health system to provide rehabilitation services. And it is not strengthening rehabilitation per se. It is about strengthening the system, as it has been already said several times, so that the system is in the position to deliver quality rehabilitation services. And this implies that we need to develop and implement tools based on which ministries of health and countries and stakeholders can strengthen the system to provide rehabilitation services. And I would like to mention 3 of these tools that WHO has been working extensively on during the last couple of years. The first one is a tool that we call a package of rehabilitation interventions. And it is—
Sorry to interrupt, but just to let you know, you've got about 2 minutes left.
Yeah, thank you. So the package of rehabilitation interventions contain all evidence-based rehabilitation interventions based on which countries will be able to select those that are relevant to address population's needs. And I'm proud to say, and also very humble to say that today, more than 400 people, or more than 450 professionals from around the world are contributing to this work with us. That will be also help us to move the field forward, because based on it, we will be able to make an investment case for rehabilitation. The second one is a competency framework for rehabilitation that will be a tool fundamental to develop workforce in countries for developing education and training curricula and regulate workforce. I don't need to say much more about it because we are launching it this Friday, coming Friday, more or less at this time of the day. And please go to WHO webpage and register if you have not done so far, so that you learn how to utilize it. And the third one, but not last, is the Guide for Action, a tool that supports countries to do the strategic planning, to implement and to monitor the progress that we are doing in terms of strengthening health system for the provision of rehabilitation. When we started Rehabilitation 2030 in February 2017, WHO had no single country request from ministries of health to a strengthening health system for the provision of rehabilitation. Today, there are almost 50. We are active in almost half of them, thanks to the support of many stakeholders, also including USAID. And actually, I came now to the end of the 3 words. It was about equity, about needs, about response. But reflecting on these words and the essence of Rehabilitation 2030, I came also to the conclusion that I need to add a final word to pay tribute to what Rehabilitation 2030 is. And that is unity, because what Rehabilitation 2030 has achieved is to bring all the field together of rehabilitation, slowly also the field of health system towards a common narrative of rehabilitation. So summarizing, I can go now the other way around and say that Rehabilitation 2030 is about a unified response to address rehabilitation needs to achieve equity. Thank you.
Thank you very much. That was outstanding and very clear. A nice finish on unity. With that, I'd like to turn over to the next speaker, also from the World Health Organization. Dr. Abdul Gafar is a longtime colleague and close friend. He is the executive director of the Alliance for Health Policy and Systems Research at WHO, and he's also an alumni of the school. I could spend a long time introducing him, but I want to give him as much time to speak. He has many years, but over 30 years of experience as a practitioner, as a researcher, and as a research manager, really on health systems planning, design, evaluation. And I'm going to give you as much time as possible, so I will turn it over to you to tell us about where rehabilitation fits in the future of health systems. Over to you, Gafar.
Thank you, David. And I would like to appreciate the leadership of Dean McKenzie, yours, David, Barbara, Dr. Bajani, Kiki, and to my dear colleague, Larcos, but to everybody else who is here. And the reason I'm saying it, I remember defending my thesis in 2000 at Johns Hopkins, and there were discussion between Dr. McKenzie, David Bishai, and other colleagues that how can we have the rehabilitation at the systems level? And there were discussion, but it took 17 years, as Larcos said, But finally, we are there, and a lot of credit to everybody, but especially to the leadership of Larcos. So Kate, can I have the next slide, please? So I did not, there are two health systems model which are very popular. One is WHO 6 building block, and other is from the other school about the knob controls. I use this thing from one of my professors, Dr. R.D. Killman. And to me, it is more relevant to the needs which we are going to talk, especially for the rehabilitation, because in the 6 building block, sadly, we don't have the word of community as a block. So I just wanted to make a case that community would play a major role in rehabilitation, and we should consider that as part of the system, which most of us do consider. However, there are outer like sort of issues which are broader determinants, which are social, cultural, environmental, political, and that's the ecosystem. We have to look into that, because in the end, it is not only the 6 building block, but the determinants of health, which are going to make a huge difference if we want to have a system which provides better access and delivers better services for the rehabilitation. Next, please. So I just did, so I will not defend the full like science of this thing, but quickly did some sort of a bibliometric analysis just to make a case that the publications, and this include any publications by anybody, not necessarily the PIs has to be from the LMIC, that there's a huge gap in the knowledge. If we look at the number of publications in the peer-reviewed journals, in the high-income countries, there's a relatively higher focus, higher visibility because of the legislation, stronger society, stronger parliament. But in the LMIC, as Kitty was saying, is still not the case, and there are very different reasons. So this is just one way I just wanted to put it. Next, please. So we all know like there are 3 different ways of access to health services. There's economic access, there's a social access, and there are geographical access. And all these access, they play when either a decision has to be made at the household level, that how are we going to take care of a person who needs rehabilitation services. Community looks at different people, and I can tell you, like I was born in a village, still I go to that village. There's a huge stigma to somebody who need even a minimal rehabilitation services or have some sort of disability. Still a huge challenge in many cultures, even within the family, and their education and everything else plays a significant role. Same is, and these lines are not straight, these economic, social, geographical access for the community, for the delivery systems, and for the ecosystems. And I think we had some discussion when this project was conceived, conceptualized, designed, and presented. And I was pleasantly surprised with the leadership of Bachani and Barbara, and especially our colleagues in the USAID. Generally, they have very different lens than the world, but Kiki has a very, like I think, realistic view, understanding, and approach that how can we tackle with the burden of disease for the rehabilitation. But however, I think somewhere we need to also look, what is the burden of rehabilitation or disability on the family, the caregivers, and the overall society than just looking and calculating DALYs. So I just wanted to make this point and then move to the last slide, that if we want to have these things, what are the things which we need to do? One of the things, as I said, we will work with the healthcare providers, we will work with the healthcare managers, we might have to work with some legislators and the parliaments, but we need to work with the community. And I think Kiki also mentioned the word capacity. So it is not the capacities of the healthcare providers. It is the capacity of the policymakers population, which is equally important. And I know it is part of the project, but I just wanted to highlight, because in my humble opinion, the title given to me was Health Systems of Future. I don't think there's a health system of future for rehabilitation system. To me, it is simply recognition and appreciation that rehabilitation services or access to the rehabilitation is as important as we have access for child health, maternal health, or for NCDs or anything else. So I think it's a question of appreciation and recognition. And by going public and having this project with so many important and relevant collaborators, we have made already a case. But that is the work this project has to do. And then I think the delivery system at this point, especially in the LMICs, are still focused mainly on the infectious disease model and to a certain extent now the NCDs. But the problem is health systems in low and middle income countries has been completely medicalized. You go to any district health officer's office, there's hardly any person who is talking about essential health services, determinants of health, working with the community. They are just doing drugs and supplies and the medicines. And I think we need to make sure this is a disease, but this is more a social issue. This is more a social challenge. This is a social protection. And we need to keep those lenses, and that should be part of our systems approach, system thinking. And trust me, I'm working in the systems research for the last 20 years. It is easy to say systems thinking. It is easy to will use the systems lens. When you have to do it on the ground, it is not easy. It is very complex. And especially when we have to compete with so many powers who wants to have the verticalization of different intervention, when they think the community health worker has to do this thing, and they want to add it. And some people say, no, this is not important for us. So I think that is the political negotiation. Those are the political pitches. And that's not only the science we have to present. I think we need to have some sort of continuous learning as part of the project. If it is succeeding, how it is succeeding, it's not monitoring. We should learn, capture, and if needed, we should correct our course and improve. And because there are different sites, we should also share if something is working at one place, it may not necessarily work into the other place because the context would be very, very important.
Before you, as you requested, you've got 2 minutes left.
Okay, so I have 2 bullet points and I'll finish. Thank you. So as I said, ecosystem to me is very important, and we all are talking about the health systems that melted down because of the COVID-19. And to our surprise, we use the word after Ebola, fragile states. I think the quote unquote fragile states have done much better as compared to, I don't know what should I call those states which we thought are very strong and have very robust health systems. They completely melted down. So I think we need to understand that there are non-pharmaceutical interventions which are equally important, and we need to incorporate when we are looking at the ecosystem and special determinants of health. And the last thing is not that I'm the director of health policy and system research. It is my firm understanding based on my understanding of the world and the experience and working in many countries and my academic background, that context is very important, and we need to generate some local knowledge which is policy relevant. And for that, we have to have systems and policy research, which broadly we call health policy and systems research. And that is, I think, if we do all these things, hopefully we will have a health system of future where rehabilitation services are taken, get the same importance and priority which any other service at this point is given. So thank you very much. And David, back to you.
Thank you very much. Thanks to both speakers, Dr. Sieza and Dr. Gafar. Excellent presentations and challenges for us. We have a few minutes for some discussion or some questions. Let me first start off a question to both of you. The beginning of this project is about learning and acting. I was wondering if you could give us a view on what needs to be learned. Where are some of the knowledge gaps and or in fact data gaps? I mean, for example, Dr. Sieza, you spoke about equity. Are there sufficient data on equity and inequity, and for which groups, for planning and management, or is it that we need more knowledge around the experience and sharing that kind of experience? So maybe I could turn it over to you first, Dr. Sieza, or to get your reflections around knowledge gaps. What needs to be learned?
Actually, in terms of rehabilitation, everything what we could think in terms of health system, we need still to collect the evidence so that we can learn. It is really in the area of workforce development. It is in the area of the impact of policies. It is in the area of community engagement. So you can go on and on and on, because actually if one would ask me what is needed now, is really to start collecting this evidence at the system level that we have not done so far, something that we have not done so far in the field of rehabilitation. And that is also the reason why this project is so timely and so fundamental, because it will provide also a starting point and provide an example for how to move the agenda in the future, and make sure that whatever we do from now on is based on what we have learned. Yeah.
Excellent. Thank you, Gafar.
So 4 things, David. So I think, as Larcos has said, there's not sufficient data, and that's the quantity of data, but also I think the quality of data. And when I say I'm primarily looking at the low and middle income countries, so the quantity is not sufficient, quality is not at that level, and there are different reasons. And then data for decision making is not available because there's a little bit of different data. And then learning and acting, there's a very little demand at the senior policy level or at the program managers level or the implementation level to learn and act. And that's a bigger mindset which we need to work, but I think we have the opportunity because rehabilitation is a relatively new area, and so it will have an initial higher impact to the listening capacity of the policy and decision makers. So I think we have a window of opportunity where we can present, if we need better data and focusing on equity, it may resonate very well with the people in ministries of finance and planning. But in simple word, I think we need to have more data, and especially if we want to disaggregate data for equity or other determinants.
Thank you. Luciani, we've run out of time, but there's some really good questions in the chat. Do I have opportunity to maybe take one more question, or do you need to move on?
Yeah, I think we can take a couple more questions.
Great, thanks. So there's 2 related questions from Maximilian Zimmerman and Evelyn Chirot, and apologies if I'm mispronouncing your names. Related to this question of integration. And one is about how do you integrate a cross-cutting program like mental health and psychosocial support with rehabilitation. And the other is about looking at how do you integrate across other sectors, focusing on data systems, but also workforce development. I have the feeling these are the kind of questions that you're going to be tackling over the next 3 to 5 years at the minimum, but just would be helpful to hear reflections from both of you about these integration challenges. Gafar, do you want to go first this time?
Happily, David, thank you very much. I think there are 2 points we have to look. There's a system, And there's a system at the policy level, and there's a system at the operational level, which is district health office and below. And we need to consider that if we have to integrate the services or policy making, then these are two different things. I think it's relatively easier to integrate that mental health, psychosocial health services and other sectors, relatively simple at the Ministry of Health, especially with the push for the SDGs. It is relatively easier to integrate all these services at the district level. However, the real distortion comes when there are some major vertical programs and they make a push, like it would be MCH, it would be HIV/AIDS or others. And there we have to be very careful, are we creating another vertical program? And that may not be the best thing, but maybe initially a serious option we have to consider. However, either at the healthcare level, district and below, or even at a tertiary care hospital level, there I think we can integrate all those things relatively easily, but it may be difficult if you want to have a connection with the policy and power corridor and at the delivery level.
Thanks. Dr. Sieza, would you like to respond as well?
Perhaps only to add a point that is especially fundamental in rehabilitation, because we are emphasizing a strengthening health system for the provision of rehabilitation, but we need to be aware that in many countries, rehabilitation services are not even under ministries of health and are really sometimes in pension insurance funds and creating parallel systems in the provision of rehabilitation services. And the message and the objective would be that to focus on the delivery of services at this point at community level and integration at all levels independently where the financing is coming from. And I think creating this awareness, especially for rehabilitation, and the discussion about the different sectors in order to achieve that would be fundamental in order to not create parallel systems, but a unified system, then again, independently where funding is coming from.
Thank you. I see there's a number of further questions in the question and answer. Many of them have to deal with both raising some of the real challenges around equity and in difficult contexts of points that you have both made, but they also are about the scope of the rehabilitation program itself, which I think is really the subject of the next session. So what I'd like to do is actually transition over to that, and first of all thank the speakers, Dr. Sieza and Dr. Gafar, for really setting out a really exciting agenda of work, taking rehabilitation out of the cage, taking on a massive learning and acting agenda, which it's really quite exciting to be at this particular juncture in time. So thanks also to the participants who've raised some questions, and I hope we'll be able to follow them up both in the next session and following up from that. And with that, I'd like to turn it back over to you, Abdul, for the next session. Thank you.
Thank you, David, Larcos, and Gafar, for the really very interesting and thought-provoking presentations, as well as discussion. There's clearly a lot that all of us need to contemplate as we embark on this journey in a unified way, to use Larcos's words. And I hope that these discussions really will continue so we can all learn from each other and collectively make a difference in this space. As David mentioned, it's now time for our next session, where we hope to provide an overview of the Relab HS program, and we also have an exciting panel discussion lined up. And to guide us through this session, we have fellow Relab HS team members, Rachel Lowe and Daphne Sorensen, joining us. Rachel is a physiotherapist, digital innovator, and entrepreneur from the United Kingdom. She is president of the Physiopedia charity, CEO of Physiopedia Plus, and co-founder of both. Rachel is passionate about utilizing technology to share rehabilitation knowledge, empower the profession, and elevate standards of practice globally. She has a 15-year history of providing e-learning and technology support to the international rehabilitation community. Daphne is president of Miracle Feet, overseeing the organization's global program and staff. Miracle Feet is expanding access to the non-surgical treatment of clubfoot. That's a leading birth defect and treatable cause of disability that affects millions worldwide. Daphne has 20 years of experience in international development, social justice, and child and human rights, leading teams across Latin America, Africa, and other settings. Before joining Miracle Feet, she led programs at the Lumos Foundation, Save the Children and Care, and has lived and worked in Bolivia, Mozambique, Panama, Uganda, and Angola. So to lead us through the next part of today's event, I'll hand it over to Rachel, who will provide us with an introduction to Relab Hs, and Daphne will then chair a panel discussion that follows. Rachel, over to you.
Thank you very much, Abdul. So I'm delighted to be the person today who is presenting the Learning, Acting and Building for Rehabilitation in Health Systems Consortium. We are a group, next slide please. We are a group of organisations with expertise in health systems and implementation science, workforce development and service delivery and capacity building. We are Johns Hopkins Bloomberg School of Public Health's International Injury Research Unit, the Nozzle Institute for Global Health at the University of Melbourne, Humanity and Inclusion, Miracle Feet, Physiopedia, and UCP Wheels for Humanity. Next slide. So together, we're all very motivated by this need to address the needs for rehabilitation and finding ways to overcome the challenges of addressing this need and integrating rehabilitation into health systems. So as Larcos talked about, the need for rehabilitation has already been discussed and is very evident these days. In responding to this need, there are many challenges. These have also been discussed before me today and are also listed here. And so collectively as a group, as a consortium, we're looking for ways to overcome these challenges. In response to population health changes, many health systems are currently in transition. And I think this is an opportunity for us to bring rehabilitation to the forefront of this transition. Next slide. So our overall aim for the consortium is to contribute to global efforts to strengthen rehabilitation in health systems and to support the development of health systems that are inclusive of rehabilitation care and assistive technology, all with the long-term vision of improved health and well-being that leads to healthy economies and socially inclusive societies. And next slide. So how are we going to do this? We will be taking a person-centered approach across the whole lifespan. There will be wide stakeholder engagement and community participation to develop and implement interventions that are innovative, cost-effective, comprehensive. And then also to build local rehabilitation capacity through the development of demand-driven and contextually relevant resources and tools. This approach will all be centered around the principles of implementation science and systems thinking, using the experience of our organizations within the group. Next slide, please. So our activities can be broadly grouped into 5 themes. I'm just going to run through these themes now. So the first theme, supporting the rehabilitation sector leaders to catalyse and strengthen a national and sub-national agenda for rehabilitation in health systems. In this theme, there will be activities to understand local rehabilitation situations and then to facilitate policy and prioritisation. Next slide. We'll be generating new evidence and information about the integration of rehabilitation into health systems, This will be through policy simulations, economic analyses, and rehabilitation assessment modules. All the new information and evidence that we develop will be made available to policymakers and other stakeholders for timely policy and programmatic decisions. So there will be wide stakeholder engagement and to use the new evidence that we develop for policy and to support leadership and capacity development. This will all be achieved by a cross-cutting knowledge management and communication strategy with policy simulation tools and a leadership academy. For the workforce, we'll be supporting the workforce at all levels of care to improve rehabilitation capacity and links between the health systems and rehabilitation care. And also through targeted rehabilitation task sharing where that's appropriate. There will be digital tools developed for facilitating communication and mentoring, learning and development and knowledge sharing. And then we'll create the conditions for the uptake of these new resources. Next slide. So the final theme, final but not last theme, is developing and testing rehabilitation service delivery models that are assistive technology inclusive and use tele-rehabilitation technology. Across all these themes, there will be many activities. They will all encompass gender equality and social inclusion strategies that will be incorporated into all project activities. And then there will also be a scale up of the solutions through accelerator grants. So across these themes, as I said, there will be many activities and everything we do will be centered around an iterative development cycle of learning and acting and building. So we'll be learning, with everything we do, we'll be learning, generating evidence and gathering knowledge. We will act upon that learning and then build new solutions and implement those in a continuous cycle of learning to help us to integrate rehabilitation into health systems. So that was a very short introduction to our consortium, the Relab Hs Consortium, and what we will be doing. I'd like to hand over to Daphne and the panel now, who are going to talk about how Relab Hs can, through these activities, shape the health systems of the future.
Thank you, Rachel. Well, it's an honor to represent Miracle Feet in our discussion today. At Miracle Feet, our strategies target clubfoot treatment, but our approaches align with interventions for a range of treatable disabilities. A referral pathway that works for a common birth defect can also serve those who need wheelchairs or crutches, as well as physical therapy for people who have had strokes or accidents and more. So through what we learn by addressing clubfoot with our partners on Relab Hs, we hope to develop practical tools and protocols that can better reach those with other major musculoskeletal conditions and injuries in our target country's primary health service delivery. Now we're going to spend our remaining time today discussing the concrete ways that we, as partners in this important consortium, look forward to shaping delivery of AT and rehabilitation within health systems and what we hope to accomplish together in the next 5 years and beyond. We have a lot to cover, so I'll start by briefly introducing our panelists, who I'm excited to speak with today. So if the panelists can turn on their cameras, and I will introduce you all. First, we have Lesa Kalandiak, who is UCP Wheels for Humanity's Technical Director with over 20 years of experience developing the PT profession and rehabilitation in Ukraine. She's a Canadian-trained physical therapist and founder of the Ukrainian Association for Physical Therapy. Perth Rosen is the Senior Director of Programs at UCP Wheels for Humanity, where she has led a health systems approach to assistive technology-inclusive rehabilitation since 2016. Prior to joining the rehab and AT space, she integrated health products and services across health sectors, including rehabilitation and assistive technology, HIV/AIDS, water and sanitation, nutrition, and reproductive health. Next, Chiara Retis with Humanity and Inclusion in Cambodia is a physiotherapist trained in Italy who specializes in neurological conditions. She has almost 2 decades of experience in policy reform for and the delivery of physical rehabilitation services. Chiara is passionate about global health issues, inequalities in health, and the integration of rehabilitation into health systems, including in disaster preparedness and response. She is the interim program manager of Relab for HI. Last but not least, Mohammed Iqbal, who is the disability, gender, and age specialist with Humanity and Inclusion in Pakistan. As a disability researcher, he has conducted a number of studies on disability-related issues in Pakistan, the most important being the submission of the alternative report on the implementation of the 2030 Agenda in line with the CRPD in Pakistan in 2019 to the UN through the International Disability Alliance. Welcome to the panelists. So Lesa, I'd like to start by asking you to share from your experience, why is it challenging to integrate AT inclusive rehabilitation into health systems?
Hello, thank you very much for the opportunity to participate in this panel discussion. I will attempt to describe the challenges involved in integrating AT inclusive rehabilitation into health system in Ukraine. While these challenges cut across all of the WHO health system building blocks, I will focus on just the governance building block. And Perth will subsequently describe how to address governance-related challenges in her follow-up remarks. The rehabilitation sector is overseen by various ministries in Ukraine. The Ministry of Health and Ministry of Social Policy are primarily responsible for rehab and AT policy, respectively. But several additional ministries are involved in the broader rehabilitation sector. These include the Ministry of Education, Ministry of Veterans, and the Ministry of Youth and Sports. Many governance challenges stem from the administrative fragmentation of the rehabilitation sector and numerous stakeholders involved. One of the key challenges is related to high rates of turnover among government ministries, which necessitates the continuous orientation of new staff to AT inclusive rehabilitation. For example, during the last 2 years, Ukraine has 3 ministers of health, each of whom appointed new deputy ministers responsible for rehabilitation. Moreover, the restructuring of the Ministry of Health in 2020 resulted in the creation of Quality of Life Directorate that includes 4 expert groups, one of which is specific to rehabilitation. However, very few members of this expert group have practical knowledge or experience related to AT inclusive rehabilitation. The absence of national strategy for rehabilitation and lack of interinstitutional coordination mechanism also complicate the provision of rehabilitation services. Various ministries form ad hoc working groups designed to address narrowly focused issues, but their activities are not aligned under a comprehensive rehabilitation policy. Significantly, the new Quality of Life Directorate expert group on rehabilitation could serve as a focal point for coordination and communication on rehabilitation policy within the Ministry of Health and between other ministries and stakeholders looking ahead. But the national strategy on rehabilitation could also help create a pathway for coordination. Overlaps in regulatory framework are another key challenge. And this challenge weakened the administration of rehabilitation sector. Currently, rehabilitation is regulated by 2 laws. The 2005 Law on Rehabilitation for People with Disabilities and 2020 Law on Rehabilitation in Healthcare System. Under the Law on Rehabilitation, for people with disabilities, the government can only provide assistive technologies to people with disabilities. Persons in need for AT must first apply for disability status to the Medical Social Expertise Committee. Application for disability status is a lengthy process that can last up to a year. And it excludes elderly people as well as people who need temporary use of AT. Even among successful applications, the process complicates the early stages of rehabilitation by limiting their access to assistive technologies until they have acquired disability status. The last challenge I would like to mention is AT products are not included in the universal health care packages. In Ukraine, the government supports the provision of approximately 30 different packages of care, 3 of which are specific to rehabilitation. Unfortunately, financing for assistive products is not included in any of the packages. Thank you for your attention.
Thank you, Lessa. Chiara, let's talk about ownership and buy-in from the people who matter most, the end users. Now, Relab is committed to including end users in all phases of the project, from initial consultations to the testing of new technologies, to ensure they meet people's needs and make sense. Can you tell us a little bit about how this will happen? Share some examples.
Sure, thank you, Daphne. Okay, I will go over a few examples of approaches that have been used also in other programs and that will be integrated and adapted within the consortium partnerships that we have created. So the very first step to ensure the inclusion of users in the rehabilitation process is to know who are the people who might need rehabilitation services and what are their characteristics and what could limit their access, what could leave them behind, basically. Going back to the issue of equity that has been mentioned earlier by Larcos. So we know that exclusion is caused by several factors, compounding factors. They are always combined. They are not only individual factors, but also environmental factors, including attitudes of people, not only physical barriers. So it will be important since the very beginning of the project activities to consult with the largest representation of users so that we can see different profiles, different types of characteristics, and we can hear from them what are the needs and to help design the activities. So we will do this through consultations, not only to understand the barriers actually, but also to identify enablers and good practices on which we can build on. And this will engage the users and engage the communities for more effective and responsive activities. This participatory approach has been used by China in many programs, not strictly related to rehabilitation, but that is also the interesting part. It has been used to develop, for example, inclusive health information campaigns on health and reproductive, sexual and reproductive health, sorry. So it will be adapted to the priorities of rehabilitation. Another very important way to involve users is to have them participate actively in the planning of rehabilitation services and the monitoring of services. So this is possible if the voices of users are heard, if there is meaningful participation, and that can happen when also users have the skills, for example, advocacy skills to do that. So within Relab's activities, there are some activities related to trainings on advocacy skills, targeting users, but actually involving all the stakeholders with a multi-stakeholders approach. This is the most powerful way of unifying the voice. I'm going back again to a concept that has been mentioned earlier. And so users will be, representatives of users will be supported to speak at national events, local events, and also international global events. A third example that I wanted to bring about the approaches, inclusive approaches, is around actually the clinical rehabilitation process. So users should receive all information they need to take decisions on their treatment and even participate actively through self-management, for example. And this is possible, and the caregivers as well. And this is possible only when the healthcare workers are also skilled to do that. So, for example, HI developed modules for rehabilitation workers in emergency context to focus on education, for example, of users as a powerful way of engaging them in the process. And it will be used by all partner members of the consortium for training activities. And the very last thing is about also the participation of users in innovation, in the design of innovation technological solutions. In the real-time feedback of users is the most effective way of constantly improving prototypes or new solutions. And this, of course, will be also an approach that will be used for tele-rehab and other innovations that will be developed within Relab Hs. Thank you.
Thank you, Chiara. So many great examples. I specifically like that you brought up the issue of meaningful participation and how important it is and how incumbent it is on us as Relab practitioners and implementers to ensure that that meaningful participation happens. So thank you. So Mohammed, I'd like to bring you into the conversation. In your opinion, what do you think needs to be in place for integration of rehabilitation into health systems to occur?
Thank you, Daphne, for giving me the opportunity and to speak to this fantastic event. So I'll keep myself on 4 points. First, the needs of the rehabilitation of persons with disabilities and aged population is largely not recognized by the government policies and programs in Pakistan. Consequently, we remain on the traditional and the medical approaches, so where the client is receiving or subjected to therapeutic interventions. In that therapeutic interventions, there is no choice for such people on rehabilitation services. It is really threatening for the country having more than 60% population in rural areas who are even hardly receiving health services or access to health services. So it's really the time to rethink about our policies, programs, and the rehabilitation services to adopt the person-centered approach for more sustainable, reliable, and integrated health system and health rehabilitation system for all. Secondly, persons with disabilities are the most marginalized segment of the society due to the fact of the extreme poverty among them, and that is not even in Pakistan, it is across the globe. And along with this, there are a number of visible and invisible barriers which are hinder their full participation in the society. Beside this, there is no option and choice or place for persons with disabilities within the health system for disability-related cost, and due to which a number of people who need rehabilitation cannot access to the physical rehabilitation, and therefore they remain on the receiving end, stuck in their homes, and there are a lot of there is no system for them in the health system. So to overcome this, we need a comprehensive rehabilitation program throughout of the health system at all level, primary, secondary, and tertiary level of rehabilitation, so that we can, a large number of people with disabilities and those who need rehabilitation get access to rehabilitation. Thirdly, the rehabilitation services in Pakistan are limited to 2 or maximum 3 cities in Pakistan, due to which a large number, 60% population, cannot access these particular services. Above this, there is no referral mechanism or an identification. There is no identification of an assessment of persons with disabilities, which can be used for referrals and using the rehabilitation services. Therefore, we need a training of the health professionals on rehabilitations and identification and assessment of persons with disabilities for rehabilitation services. along with the curriculum, the rehabilitation curriculum to be adopted so that we can generate evidence regarding the rehabilitation for future in Pakistan. The last point from my side is about the assistive technology, which is extremely limited in the updated assistive technology in devices is extremely limited in Pakistan. Only those can, achieve or receive them who can access and afford them. The rest of the population, the 60% again, who has prone to disasters and no awareness among them, is just cannot access to the rehabilitation and assistive technology, or otherwise depend upon the non-customized devices coming through the social protection systems, which increase their vulnerability. To achieve the self-autonomy of a person and provide them the freedom of choice, the assistive technology should be available in large scale in the health system, so that persons with disabilities can achieve them. And the provision of the assistive technology should be based on the desegregated data of persons with disabilities, so that we can respond to the level and types of barriers, as well as the support requirements of persons with disabilities for more powerful and long-lasting rehabilitation services for all. Thank you.
Thank you, Mohammed. I think your experiences and specifically really the specific context that you were able to share with us really drive home the recurring themes that we've been hearing all morning around equity and increased access and the vulnerability of populations affected and in need of these services. So thank you for that. So Perth, now over to you. And not that I'm asking you to predict the future, but how can Relab Hs shape AT inclusive health systems of the future?
Great, thank you, Daphne. And thank you everybody for being here and the opportunity to think into the future a little bit. So to address the question, I'll be circling back to where Lesia left off and illustrate how Relab may shape AT inclusive rehabilitation health systems. But before doing so, I really want to recall that Relab takes as a starting point that rehab services are at different stages of maturity in each of the 4 countries. And as a result, entry points for system strengthening will vary across countries and across building blocks, which is also to say that Relab builds from previous investments, previous achievements, and national priorities, and will lend value by pulling in consortium expertise together with wider stakeholder input, many of you on this call, so as to further national rehabilitation strategic planning, service development, workforce capacity development, as well as to strengthen or establish coordination and communication mechanisms, and ultimately translate all of this knowledge across countries and across different communications platforms. So with that said, returning to Lesia's point on rehab governance challenges, we'll concretely address this challenge of frequent turnovers at ministries, which, as Lesia noted, necessitates continuous orientation of new staff to rehabilitation priorities and thus inhibits coordination by building upon previous WHO-led AT and rehab assessments, and will, through partnerships with relevant ministries, advance an AT inclusive rehabilitation strategic plan. So an important step towards operationalizing a strategic plan that encompasses multiple ministries is the development of cross-ministerial committees and technical working groups. And practically speaking, by formulating terms of reference that flow from strategic priorities, Relab can achieve concurrent progress across ministries towards a single set of objectives. And these efforts will be supported by knowledge management, technology-enhanced communications tools that can track progress, align priorities, and allow timely expert input, which we see as a key to building national confidence along the maturity continuum. So taken together, it's expected that adherence to a cross-ministerial strategy can insulate the ministry from the effects of turnover and advance in tandem with government urgency. So Relab will further strengthen governance by providing timely and expansive technical assistance across working groups, drawing from the full consortium, to shape a regulatory framework that's rooted in practical rehab-specific measures that bridge gaps and reconcile divergent laws in support of the strategic plan for the full rehabilitation sector. So in parallel to this, the project will demonstrate how a unified AT-inclusive service model can function in practice. The model will include centralized procurement and dispatch of select assistive products provided with service and referred for follow-up across all care levels. And importantly, as is noted today, including the community. So these cross-ministerial working groups provide a platform to ensure that these types of demonstration projects align with iterating national plans, as well as to allow project learning to feed into AT-inclusive rehab package design. So as with this example of strengthening governance in a particular context, the context of Ukraine, Relab's broader health system strengthening activities will similarly serve as a source for case studies, field-tested planning and management tools, capacity building guidance, and policy policy recommendations that cover each of the systems building blocks. And then when taken together, the project's implementation in each of these learning countries can yield insights into methods and strategies for integrating AT-inclusive rehab into national health systems.
Thank you so much, Perth. You did a great job of predicting what we will be doing and laying that out very beautifully. So this has actually been a very rich and interesting conversation, and there's certainly a lot of work to do over the next several years, as we've been hearing. We are all very excited about a lot, but as we wrap up this panel, why don't we go around and just share one concrete thing that we're really looking forward to accomplishing as part of Relab HS. And why don't we kick it back to you, Perth, and you could kick us off.
Yeah, so for me, the pairing of such a rich resource within this consortium with the strong appetite at the country level to move the agenda forward is a opportunity that we haven't seen and inspires great confidence in the outcomes over the next 5 years.
Wonderful, thank you. Mohammed, how about you?
So the concrete the thing that we want to achieve from the Relab HS is actually to draw in evidence regarding the rehabilitation and also link it with the overall health system in such a manner that, you know, transform our rehabilitation model to the person-centered approach where it works for everyone and for everyone for a longer time and to sustain it. We want to achieve a predictable, reliable, and universal sort of rehabilitation services throughout the health system.
Absolutely. And Chiara, let's go to you.
Well, you asked about a very concrete result. Yes. So it would be great to see in 5 years' time, for example, any frontline workers or primary health workers in the countries where Relab HS is intervening that has included in their routine work the identification of rehabilitation needs, is able to provide information to people and to provide basic support so that people can access all the levels of services that they need.
Yes.
Thank you.
Thank you. Thank you so much. Lessa.
Well, for me, I think that the best result would be implementation within the country, because it was mentioned by one of the speakers that implementation is the most challenging thing in the process. So
Yeah.
For me, the implementation of learning, acting, and building would be the best result.
Yeah, I hear you, and that's what I was thinking of too. I was just reminded when Dr. Gafar mentioned the issue of stigma during his presentation of disabilities and rehab services. You know, in the case of Clubfoot, the treatment through the Ponseti method is so inexpensive, non-surgical, and 95% effective for the one in approximately every 700 babies born with it. But I think now through Relab, and what I'm really looking forward to is supporting the rights of all children to access this treatment in their village clinics, in their primary healthcare facilities, or anywhere else health services are available as part of what we've been talking about, right? An integrated approach to health services. So thank you all. I think this has been a great panel. It's wonderful to hear from everyone. And I will hand it over to the person in charge of making it all work and putting it all together, Nabil.
Thanks, Daphne. Thanks so much for moderating an extremely insightful panel discussion. I really enjoyed it. I particularly enjoyed how the panelists gave us a glimpse of how it can all look like in the field and how interventions can reach to the people who matter most. We have discussed a lot of challenges, but we are all committed to get to the goals as well. This strategic investment of US government through Relab Hs project towards integration of AT inclusive rehabilitation into the broader context of universal health coverage and health systems is, to my mind, is simply groundbreaking. It has the potential and commitment to transform lives in many countries around the world. But it is not possible, though, to achieve our goals without the involvement of you all from all walks of life. Let's join hands to achieve our goals because only together we can achieve. Along with Dr. Abdul Bachani and Dr. Barbara Mcpeak, I would like to sincerely thank all of you and all our distinguished speakers from WHO, USAID, Johns Hopkins University, and Nozzle Institute for Global Health in University of Melbourne. You helped set the tone for not just this event, but also for Relab Hs project and the exciting work that lies ahead of us. Thanks to our panelists and our valued partners in the consortium, Miracle Feet, Physiopedia, Humanity and Inclusion, and UCP Wheels for Humanity, for such a lively discussion and bringing bold ideas to the ground and in the context of the countries and populations that we will serve. I also want to thank our communication coordinator, Kate Hawkins, and her team, Eric Schulman and George from GHU Multimedia team, and also our program technical coordinators, Nuk Bazia and Wesley Pryor, and my colleagues and friends for their hard work behind the scenes for making this event possible and a success. It takes a village, as they say. But most of all, it is the participation of all of you who have joined us on the virtual event that has made this event special and has enriched it with your comments and suggestions in the chat box and all the questions and answers that we have. Thanks all for joining and participating. This is only the beginning of our interaction. Have a wonderful rest of your day or evening, depending on where you are in the world. Thank you so much.